And welcome to tonight's webinar. Thank you for joining us. And we have a tremendous group from all over the country. That's the interest that you have in tonight's webinar, which is very exciting for all of us. This webinar is brought to you by, or our sponsors are BioHorizons, Gilead Dental Marketing, YourMarketingPractice.com, Stella Life, and Ace Chat. All of these companies have been kind enough to sponsor these webinars in order to be able to make sure that they come to you. And these are all companies that I've worked with. I'm Dr. Lee Sheldon, for those of you who don't know me. The people that we're going to be working with tonight, the first is Dr. Colin Richman. Colin and I have been friends ever since graduate program at the University of Connecticut. We won't discuss what year that was or what years those were. And Colin and I have remained friends throughout our entire careers. I've followed Colin and seen what Colin has done, and some of the things that Colin has done are just amazing. You'll have the opportunity of seeing that tonight, along with two fine practitioners who are supporting Colin, and Colin is supporting them. Dr. Estelle Zanstra is a prosthodontist in Atlanta, and Dr. Jim Gray is an orthodontist in Atlanta. The three of them work together, and you're about to see some amazing treatment results. And this is going to be an outstanding treatment planning session. So Colin, Estelle, Jim, over to you.
Thank you, Lee. So I hit share. And then I hit here. And then I hit share. And I assume we're on.
You are on.
Okay. Lee, thank you. I would like to really thank my friends and colleagues, Estelle and Jim, for taking the time and the effort to prepare for tonight and for being here to share this case with us. And I think the most important aspect of this case, yes, the result is nice and we've got a fantastically happy patient and the case is holding up well. But looking at the interdisciplinary approach to dentistry, that is what our mission is tonight for this audience, to take away that through efficient teamwork and mutual respect, we can really do wonderful things for our patient in terms of their dental needs. So I'm going to go into the case, and the rules for the case, I believe, are that if people have got questions, they will direct them to you, and that at the end of the session, we will address those questions. Okay, I am having a little issue here. Mark? Okay. That is me.
Here it is.
What, Mark?
Colin, I'm doing it with your scroll.
Oh, okay, all right. So okay. the first slide is a little propaganda, and the propaganda tells us that delivering a successful outcome includes, and these are for patients with mutilated dentitions, for patients who've got minimal treatment needs across the entire spectrum. In order to achieve comprehensive care for that patient and for that patient's needs, we need a comprehensive exam. We need thorough diagnostics. We need diagnostics in the worlds of periodontics, structural as per Coyce, which implies teeth, functionality, which is how all the components work together, and aesthetics. And many of the major teachers from around the world have defined the 4 food groups in dentistry as Perio, structure, function, and aesthetics. People like Spear might give them different titles, but in essence, they are the same. We then need a comprehensive treatment plan with appropriate diagnostics and analysis of etiology in each of those categories. We then need to have acquired, or we need to develop the skills at case presentation, and in this case it's the group case presentation. Then we need to talk about treatment planning of those 4 categories, And then we need to look at predictability, short-term, long-term. And in other words, we need to be treatment planning in the fourth dimension for our patients as to what will last and what will be viable over time. I'm using a different mouse here, so it's a little sensitive. And please bear with me as I get used to this. Now, we've come up with a treatment planning workshop to achieve a worksheet to achieve comprehensive care. And this sheet is available from us, from Lee. Anyone wanting it can contact our office or send us an email, send Lee an email, and this worksheet is readily and enthusiastically available. And this is designed to try to get through the steps that nothing gets lost along the way, because with so many of these more interdisciplinary cases and multiple providers, these patients so frequently fall through the cracks. So it starts out with the provider names, phone numbers, and emails. And by the way, all of these communications are always shared with the patient. They get copies of everything we do. Then we start gathering data. Data will consist of the histories, the chartings, photographs, radiographs, models, CBCT, and other items. And you can see we've just used the first letter of the category, and that gets put into the box on the bottom relative to the data we've gotten and that we can then share. Next page, we then list the proposed procedures from 1 to 12 or longer in the order that's needed, who's going to provide what, how long it'll take, in other words, timelines, and the sequencing where that will fit in. And then I do believe in these bigger cases where there's multiple officers involved, we need to look at fees, so the patient up front knows what sort of price category they're in for, and if they're going to need financing, or if they need to phase it, or if they want to just write a check or whatever, and we can put there an estimated fee. And then we are learning more and more through fantastic research being done by Nobel Biocare that where there's multiple providers, a global fee is much more commonsensical to the patient than everyone presenting their own little individual fees. So that is available, and I hope you might consider using it. All right, let's move on to our patient, Brenda. Brenda is a healthy Caucasian female. Her only medications that she takes that I'm aware of were for migraine. And still, if I remember, migraine was quite frequent for her. She denies allergies, smoking, systemic disorders, and she has vitamins for dry eye. We look at this and we wonder, do any of these medications have any kickback to the oral condition? And we will learn about that as the case progresses. In terms of her dental history, we see that she's current, she's conscientious with the maintenance dental care. She had, at the time of initiating of exams and treatment, she had no active dental disease in her mouth, in other words, caries or periodontitis. Her previous dental treatment history was she had over her lifetime extensive ongoing dental care. In other words, some of us might describe that as patchwork. And what does the patient want? She wants functionality, predictability, and aesthetics. Now, this lady she's since retired, since we treated her. She was the office manager in a terrific prosthodontic office, namely Estelle's office. And she had seen over the years, she's a very astute, bright woman, she had seen open embrasure spaces. And I was told that she had delayed seeking comprehensive care because of her fear of ending up with open embrasure spaces, and we were very respectful of that request. So one of her concerns were no open embrasure spaces, and that's a very mature statement for a patient. Moving on, when she came eventually to my office, and from the information I've gotten from our colleagues, our diagnostic findings were no extraoral issues. Her joints and range of motion seemed normal. From what I recall, we did a very scientific evaluation of opening, in other words, 5 fingers, and that was good. Functionality seemed normal. Joint sounds and tenderness to palpation and myofascial pain seemed normal. But for headaches and migraines, she was taking Fiorinol, which is pretty potent, and Exert. I'm going to ask Estelle and Jim if they've got anything else to put in at this time. Please to go ahead. That you'd like to mention here.
Well, Colin, if we'll wait for me, this is Jim Gray, orthodontist, until we see some pictures, and
okay.
I'll kind of describe my problem list.
Okay.
And I'll do the same.
Okay, so I'm just introducing the case and some background. Some ongoing dental history. Tooth number 8 and number 9 had bonded restorations to close an anterior diastema more than 30 years ago. At initial presentation, Brenda stated that she was recently made aware that her bite was off from a T-scan, and Estelle will talk about the value of that T-scan, both as a source of information for Brenda and as well as a source of very valuable diagnostics for herself. The patient then, after much discussions with Estelle, chose to take action on the treatment plan at this time that had been suggested by Estelle, as she understood that relief from the headache pain might be a benefit of her treatment. Now we'll start to look at certain images, and Estelle, Jim, please jump in anytime as we look at that and as you would analyze the anterior view and the lateral view.
Colin, what I think is really an interesting piece of this case is that Brenda was working at my office as a new scheduling coordinator. She'd never worked in dentistry before. Her history was in nursing and patient education at an asthma center in Atlanta. She was suddenly embarrassed by her smile and asked me if she could have a snap-on smile. So we did exactly what we do for all of our patients in terms of a preclinical exam and a co-diagnosis, and discussed those options. Simultaneously, the representative from the T-Scan group came to our office, and we'll talk a little bit more about how that impacted her decision to make some changes.
Okay, great. Looking at these images, would you have any comments, Jim, from the orthodontist standpoint?
Yeah, you know, one of the things we'll see a little bit better when we take a look at our photographs is that we have a good skeletal pattern, and the malocclusion that we'll soon see is really a dental malocclusion, not a skeletal malocclusion. And so we had a lot of good protoplasm here to work with, and we'll see that as we see our preceding photographs.
Okay. As we start to look at the, do apologize for this mouse here. As we start to look at the images, these are the extraoral images. I don't have any idea of how they're projecting through all of this amazing software, but if you look at the case, you will see the 2 bonded restorations on numbers 8 and 9 to close a diastema. You will see the severe crowding. You will see that there's numerous interproximal restorations, and you will see that the color is certainly unfavorable to her. Yet with that, her gingival health and her oral periodontal health is quite satisfactory. If we start to look at the retracted images, we will see, and Jim, anytime, please jump in, Estelle, jump in. We will see significant severe crowding from the periodontal aspect. We see a hyperactive Freenham on tooth number 24. We see a variety of restorations. And one of the things that's interesting that we'll come back to is very prominent tori in the maxilla and very thick bone in the mandible on the facial, and it was to a less extent on the lingual. Any comments on these images, or moving on?
Yeah, let's look at some more pictures.
Okay. As we move on, looking at the lateral view, on the viewer's left, we see again these tori in the maxilla and very thick buccal bone in the mandible. We see the same on the right. We see some very modest recession on the teeth numbers 12 and 13. She's had a number of crowns. She's got a large number of amalgam restorations.
You guys note also that what was most favorable is this class 1 molar relationship that we see on both sides.
Yeah, go ahead.
You can see on her left side that she has quite a challenging crossbite, kind of what we often refer to as a Brody bite. And that creates some future challenges, which we'll talk about in the future this evening.
Still?
And from a cosmetic perspective, she was concerned about the premolars, which have a gray appearance and were showing through from the old amalgam fillings.
Okay. Was she concerned about the shortness of her clinical crowns, especially on that right?
At that time, that was not a major concern.
She was
It
unaware.
was something that we brought to her attention and was part of our initial discussion.
And to the audience, I'd like to point out, because we're going to come back to this, the shortness of the clinical crowns, especially on her right side. Okay, moving on, just looking at the anterior retracted view, we see what we see, and we see the need for a lot of future orthodontics.
Yeah, obviously excessive overbite and overjet. And we see the gingival recession. And I don't know if we have at some point I was hoping we'd see a facial photograph with her smile where we could see her cant to her anterior occlusal plane.
Okay.
Brenda wasn't enthusiastic about looking at the orthodontic option because she had been told at previous orthodontic consultations that the procedure would take 4 years to complete and orthognathic surgery would be required. And I asked her to revisit that, and she did that.
Well, thank goodness. Okay, moving on. Looking at the arches, Jim.
Yeah, we can certainly see a very much a lower arch, very constricted, as well as some maxillary arch constriction as well. And maybe not in this photograph, but a little bit of maxillary incisor protrusion. To kind of complete my thoughts on this, there was a few other things that we identified orthodontically. One was a mild Bolton's tooth size discrepancy with mandibular excess. And we note also, we haven't mentioned it, but of course we can see now that there's plenty of anterior attrition.
You know, it's interesting today, and I don't recall if this was done when we started the case way back, but today, of course, this would be a trigger to also start thinking about sleep and sleep issues. But I don't think it was addressed when this case was done because we weren't thinking so much regarding that. All right, so from the periodontal standpoint, remembering we've got 4 categories to address in working up the case of periodontics, of teeth, of myofunction, and of aesthetics. In the periodontal department, I pretty much initially was redundant. Gingival health is excellent. Lee, you'll be happy to hear we still do a GI and a PI on every patient. All these years later, having been influenced and indoctrinated by our joint mentor, Harold Lowe,
You're such a good
And,
boy, Colin.
Thank you, Lee. I knew you'd like it. And her gingival index was 0.1, which is almost perfect. Plaque index 0.1. So she is, and at that time was, and she still is terrific. In terms of gingival recession, we noted on the left side, on the maxillary bicuspids, some modest recession, and we noted some significant recession in the mandibular anterior, as you can see from her charting, and this came from Estelle, that there's no bleeding on probing. Gingival health is excellent. You can see here perhaps lower anterior, marked in red, 4 millimeters of recession on 25. I'll carry on and just point out that from the radiographs that we see, she's had numerous restorations. In a long-term case, especially if there's long-term orthodontics, I'm always concerned in a case like this about recurrent interproximal caries and meticulous maintenance throughout that orthodontic phase. Of course, today with different therapeutic modalities like Invisalign, that is easier to maintain, and we always make that a major part of the treatment planning. But in essence, bone levels interproximally throughout the mouth are excellent. Brenda certainly might have been described as much more vulnerable to caries, much less susceptible to periodontitis. Notice the restorations. I'm just seeing if this mouse will move. Notice the interproximal restorations between numbers 8 and 9. Looking at the panoramic, it's relatively uneventful. We see the crowding as such. Anything you'd like to add to the radiographs? No, we're good. Moving on. Now we get to our lateral SEF.
Well, we can see from our SEF that, again, we have a nice class 1 skeletal pattern and basically a dental malocclusion. We would call her brachycephalic, if you would, but for the most part, just a nice pattern in orthodontics to work with.
Jim, I would like to ask you a question here that relates to all of us and that we've discussed in the study club. In a comprehensive care case with multidisciplinary involvement today, how important do you regard the SEF? We're seeing different approaches to the value of the SEF in terms of orthodontics today.
For me, it's very important because it's about the structure. It's about how the maxilla and the mandible relate to one another, at least. And of course, this is simplistic in that it's just an anterior-posterior relationship, but it helps guide me in lots of ways. So I couldn't do without it.
Okay. Because there have been some rumblings about the SEF's value with 3D evaluative tools today.
Well, we don't have, yes, it's interesting because we see so much with our CBCTs, but it's, at this point, it's not, we're not able to quantify it. And
Okay.
So it doesn't give you the background that a cephalometric radiograph and then decades of experience with it.
Well, that brings me to a little propaganda, and the next slide had a major impact on me. And this relates to the Kokich occluso-incisal line, which is this line that I'm trying to point out with a mouse over there, and the value of that in terms of setting up a case when there's a significant aesthetic involvement. And we're not going to spend any time on that, but for those out there interested, look up under Kokich the occluso-incisal line, and you'll get more information from that.
Colin, I think that's a really important feature of the SEF. It's something that I use in setting up the mandibular occlusal plane, because the more I look at SEFs as a prosthodontist, the more I see the importance of the using these anatomical markers to set the mandibular occlusal plane for health and good ease of breathing.
And I will comment that in all of the study club cases of case studies, when we've had a lateral SEF, even if there hasn't been a major orthodontic component, it has added to our diagnostics. Right, I'm going to move on because this case is also significant in terms of the modality of therapy known as periodontally accelerated osteogenic orthodontics, or bulkodontics, or SFOT, or as we've called it in North Atlanta, pop-up pre-orthodontic periodontal augmentation. And I'm going to just throw in one screenshot to become aware of the fact that if we are expanding an arch, we need to ensure, and today we've got the tools to do so, that we've got bone to move the tooth into. Now, previously, we didn't have these diagnostic tools without CBCT, but today, look at the risk we would run if we were trying to try and expand that arch, not realizing the prominence of that tooth way out of its bony housing. So we see a representative sample, and I'm of the opinion that if we've got a thin biotype, which we so frequently have in these type of crowded cases, CBCT is almost a standard of care. Am I going the wrong way now? Yes, I'm going the wrong way. Sorry. Please bear with me. We now look at casts. And again, you cannot really work up and build up a case of this nature if you don't have all the records. And this is an essential part of the case. I'm always so jealous, if that's the appropriate word, of our orthodontic colleagues over the quality of casts they produce, and in this case, our prosthodontist casts that's done there. Is there anything you'd like to mention? All the cases that Jim undertakes gets mounted as we work the case up. I think that this is a very valuable view, and this is looking at the lingual malocclusion or occlusion, and we notice the significant, in all of these lingual views, marginal ridge discrepancies, overbites, cross bites, over eruption of lower anterior teeth. This is a magnificent view, and that's where casts, in my opinion, are indispensable.
Colin, in looking at those models, a restorative dentist might look at those models and be tempted to open the bite on the articulator, to use veneers or some other masking method to restore the case in a cosmetic way. And what I found is that doesn't always lead to comfort, to good function, and to the best cosmetic outcome.
Yeah.
And it by working as an interdisciplinary team, we're able to use less restorations and achieve a fantastic outcome to preserving the longevity of the teeth.
Indeed.
And decreasing risk.
Yeah, I totally agree. And Estelle, that is why records are so crucial, both short-term and long-term. Totally agree. So this is what we do in our group here. And by the way, if anybody wants this template for case studies in their study clubs, let me know, and you're welcome to this template. All we do is we take the images and we drop them into the template. It's all been pre-made, and I would love to share this, and our group will be happy to share this with the audience. Now, this is the composite where we're looking at the left side, both the casts, the clinicals and the radiographs, to give us a very nice overview as to what we're looking at. We're looking now at the right side, similar composite. Notice the extent of the restorations and a previous vulnerability to caries. Here we are looking at the anterior segments, of course, as a summary of what we have seen. So we are now going to get into what did we do for this patient as we worked up her case. And again, please bear with me. I'm not having a good time with this mouse. Initial discussions, my fingers are too heavy. Colin, don't do that. Okay. Initial discussion and subsequent case workup. As Estelle said, the patient initially requested a snap-on smile, and they had those discussions. Then these are Estelle's notes following diagnostic records, photographs, x-rays, CAS, face bow, mounting, bite registration, T-scan. She then became committed to comprehensive care. The next appointment, as per Estelle, was a comprehensive clinical evaluation and co-diagnosis, which included perio, teeth, and orthodontics, and then referral to Jim for a comprehensive orthodontic evaluation. So we are now at the point we've got her records and we're starting to analyze the records. For those of you who run study clubs, the best place to do this treatment planning is at a study club. I have just thrown in this as a tool that we use, both the SHISH aesthetic guidelines and the coming up the COIS risk factors. SHISH, you may remember, talks about the incisal plane. That is, as Jim said, the cant that's evident in her mouth, the incisal profile, the shapes of her teeth relative to her mouth, the incisal length. So far, most of this seems favorable. Her smile line seems favorable. Please comment, Estelle. The tooth proportions at this stage seem favorable. Gingival outline, from my standpoint, in the anteriors is reasonably favorable. In the posteriors, she's got a gummy appearance. Tooth shades, it looks like a rainbow there with all the different colors and the staining. Intrinsic characteristics we can't really analyze because of all the restorations. Her buccal corridors are very understated, and her lip support is adequate. Any comments either would like to make on SHISH?
Brenda wanted to have a more natural look to her smile, and this is something we wanted to honor in our restoration.
Okay. Then I love this, and this has really influenced my dentistry for the past many years. And I'm indebted to John Coyce for bringing this to us. And what John Coyce talks about is, as we treatment plan, minimizing risk. So we look at perio, teeth, functionality, aesthetics, going from a high risk, if relevant, and our treatment plan must take us for long term to a low risk. So I'll go through this quickly. If we look at Brenda's periodontal risk factor, I think we would all agree that she is a low risk periodontitis patient, and our treatment planning really doesn't involve much treatment for periodontal disease as such, or periodontal susceptibility. Tooth-wise, I think she's a high risk. Notice the extent of the restoration she's already got and the largeness and size of some of them. Functionality, she seems to have problems there, could be a high risk, but I think in treatment planning, both teeth and functionality, we can plan it so we move her into a low risk for future success. And aesthetically, I would have said she's a moderate to low risk, and that we certainly can provide her with a treatment, except when she told us about no embrasure spaces to be visible. Suddenly it went to a very high risk, because every one of us knows that if you're going to expand an arch, you might lower the contact, lower the contact point and end up with triangles, and periodontally that might be the case. So that did put some pressure on us to try and honor her request in aesthetics. But basically, I don't think there's any real vulnerability, and we can provide her with treatment as is needed.
But Colin threw this in here. This is comes from instrumentation from a SAM articulator, and we look at this orthodontically in each case where we want to, if your goal in orthodontics is to put the jaw in the socket where it's supposed to be and have good functional occlusion, it's nice to know where it started. So if we look at the little SAM diagram on the right-hand side, from the red dot is actually centric relation or the hinge axis, and then the black dot is where the condyle shifts to in centric occlusion. None of this is particularly remarkable due to the amount of shift. It's not a lot of shift. On the right-hand side of the screen, on the right-hand side, yes, on the right-hand side of the screen, then we see the condyle moving down and back, and this is something that if you look at these regularly, you can associate it with certain dysfunctions, and you put this in play. You put this in with looking at the articulated models and the interferences that you see on the models and on the articulator.
And that type of analysis also lines up with the type of T-scan that we saw in using a computerized bite analysis. And that was a significant factor for having Brenda use enough logic to make the emotional decision to see Jim for the orthodontic evaluation. She realized that there was a risk to her teeth and to their overall integrity. So she did decide to see Jim.
Jim and Estelle, in a case where there's going to be a tremendous amount of occlusal rehabilitation, is this a regular tool that you use and incorporate into your treatment plan?
For me, every orthodontic case is a full mouth reconstruction.
You're totally right.
So
you're totally,
so if
that's why I love you, buddy.
if my treatment goal is to get the jaw in the socket again, as I stated before, then I like to know where it started and what kinds of mechanics I can use to facilitate that movement. All right. So when we're so used to looking at how the teeth occlude, we sometimes forget how the condyle disc complex occludes, and that's why we're looking at this information.
Did you have a comment?
I'm doing the same thing when I'm doing managing a full mouth rehabilitation. So I always want to see how the jaw joint, the muscles, and the teeth relate for stability of the porcelain, the bite, and the patient's comfort.
I guess that's crucial. Okay, so the problem list. This is just the template. As we develop a problem list, I've always said, and I've always said with respect, that in all of our residencies, I think no other residency produces a problem list as well as the orthodontics. The orthodontists, they excel at that. And every report we always get back from all of our orthodontists list the problem list, and I think that is phenomenal. Next, after the problem list, we've got to come up with 4 diagnoses: periodontal, structural, functionality, and aesthetics. We've got to understand the etiology of each category. And then, and only then, do we come up with an appropriate treatment plan after we've developed the problem list, understood the diagnoses and the etiology. Then, whatever additional consultations are needed. Now, this might seem very cumbersome, but once you've got a rhythm going, it helps everybody, especially the patient. Then we get into phase 1 of therapy, which has been known by many different categories, and basically that is disease control. It might be called initial therapy, phase 1, scaling and replaning, caries control, endodontic therapy, removal of impacted teeth, stabilization of the bite. In other words, we need to get rid of acute disease and symptoms. From phase 2, we then move into rehabilitative or reconstructive therapy in each of the 4 categories. And then after that is done, we get into the maintenance. And our patients, who are these interdisciplinary patients, are made aware of each category and who's going to do what expenses involved up front as they themselves elect to move into a treatment plan. So this was Estelle's notes to the treatment planning session. Would you like to go through those, or would you like me to?
You can continue. I think that Brenda had previously been told if she straightened her lower teeth, there would be black spaces between the lower anterior teeth. We needed to know how we were going to manage that. Jim, I think you wanted to know that she could tolerate the orthodontic methods that you were going to use. Would she accept the periodontal therapy that was recommended by Jim to eliminate the risk of triangular spaces between the lower anterior teeth? And you know, everyone can read some of these things as you put in bold those major features.
Okay. Exostoses, impressions of exostoses. Can we develop stable occlusion? Will the lower anterior teeth whiten to an acceptable shade so that an acceptable upper shade naturally coordinates with the lower? All of this has got to be determined up front. And will the elimination of traumatic occlusion significantly eliminate headache pain, a major treatment acceptance motivation? Stay tuned. Okay, comprehensive dental care. Just a summary of that slide a little while back. Any other consultations needed? Endo, oral surgery, pathology, medical, anything else? Our orthodontists in our group and us have had, and when I've been out talking to other groups, when we're going to do extensive restorative care, should those teeth with large restorations be evaluated by the endodontist prior to initiating treatment as part of the overall program? And it would seem that the consensus is yes. Then we get into disease control, reconstruction, and maintenance. All right, another one, interdisciplinary experience, looking at the four categories. But today, we need to treatment plan in the fourth dimension. What is the fourth dimension of treatment planning? The fourth dimension is time. In other words, yes, we can show a magnificent result 6 months later, but what's it going to look like 6 years later, 16 years later, and 26 years later? And how's it going to hold up? And how do we make those determinations? Those determinations are made by going to the literature. Today, we've got meta-analyses and systematic reviews on almost every topic in dentistry, in clinical dentistry, and it behooves us, and we owe it to our patients to understand what works over time and what does not. All right, according to Coyce, unfortunately, that little box is covered, but our object was to reduce risk. Phase 1 treatment, phase 2 treatment, phase 3 treatment, phase 4 treatment, proposed phase 5, proposed treatment for Brenda. Again, just an illustration using our timeline and anticipated fees. I didn't mean to do that. You can see from the initial phase of treatment, the days, the times, who was going to do what, and when, and how that fitted into the big picture. And I would speculate that this is one of the most valuable tools that we have for addressing a patient and who's going to do what, when, and where, and the global fees. We've all lost so many quote unquote big cases because the patient just got lost in the system, each and every one of us going forward. So there you see the case. You see it's predominantly orthodontics, prosthodontic, restorative case, terrific patient. So let's move into the clinical side and what we did. Okay. Initial therapy, phase 1 treatment, routine and simple. And Estelle, this was done at your office?
Yes.
Where it was...
We did, and we did manage one silver filling or amalgam filling that we felt was likely leaking. We found that there was a need for an indirect pulp cap on that. We used the biodentine for that before she initiated her orthodontic therapy. And so that was the basis of our initial therapy. As you can see, Brenda's home care was excellent, and she kept up with her maintenance visits very nicely.
Just as an aside, the dental assistant who was involved in this entire case with Estelle is with us tonight. Her name is Sherry. And Sherry, anytime you want to jump in on the treatment because you were probably closest to the patient, please let me know. Okay, then we move into, the patient went from Estelle to Jim. And Jim, you are on.
Well, we begin with the idea that if I can get the teeth in the right positions, then the restorative is easier and much better. So
absolutely,
that's where we begin. That's how I begin this process. And Estelle was so right. I think there are many instances where restorative compromises are created because the teeth aren't in the right spot. So if you have an opportunity to do orthodontics, then it makes for just a better case. To back up just a little bit, when I first saw Brenda, some of the mechanics that you see, I think, are relatively difficult. And I was wondering about the patient's tolerance to those procedures. Fortunately, we had a very motivated patient who was available really as needed. So that was very, very helpful in this process. So what we're seeing here is just a description of the mechanics that are the processes that we used. We did this a little bit in stages. I think we have some pictures that Estelle took. Can you move forward just to another slide and see what we have here? Okay. Yeah, let's go a little bit right in there. That's what I wanted to see. And we can see that we used a bihelix appliance to do some molar rotation to achieve a rounded, more compatible maxillary arch. And Colin, if you'll move to the next slide, you'll see, I think, the mandibular arch. And this is where my concern was, particularly with the tori and the constricted lower arch, where we were going to encroach even more upon the tongue space. But again, we had a wonderful patient, and she tolerated this with, I won't say a smile on her face, but she did tolerate it and do reasonably well. She didn't complain to me. She may have complained to her husband or her staff members. I don't know. You'll also note that in order to correct the crossbite, that we put some what I call turbos or buttons or bite opening composite on the molars in order to be able to correct the crossbite.
And I just think it's so fortunate that she had the buccal exostoses to move the teeth into.
Yeah.
And I think it's fascinating to watch that over time.
Now you'll notice too, go back to that space. You'll notice also that we kind of staged this. And we didn't put appliances on the mandibular anterior teeth until we had established the transverse relationship of the buccal segments. And at that point, reevaluated the needs for aligning the mandibular arch. We discussed two approaches to that. One was a mandibular incisor extraction, which would create a large two-sides discrepancy, and anybody that's ever done that understands the ramifications of taking out a lower incisor. But instead, we decided to ask Colin if he thought it was reasonable to do some periodontal augmentation and to keep the teeth. So that's how we proceeded.
And this case, I treated my component in two separate phases. The first phase is we did popper treatment for the mandibular arch. You can see in that mandibular arch, for example, these fenestrations. We can see another fenestration. We can see that we saw on the x-ray, the dehiscence over here. We do a lot of this type of treatment now. We see the corticotomy. We see the cortical perforations. We prepared the case, and then we put in all of our grafting agent. And if I remember this, Jim, it's been a while, but I think we went from the second bite to the second bite bilaterally. Over here, for example, where you see this prominent ridge of bone, that gets reduced because moving these teeth through that pretty much fused cortical plate is very difficult, very time consuming. So we thin that out. We'll do the corticotomies to set up the osteopenic effect and truly facilitate and enhance the orthodontic endeavor.
If you'll stay on that slide for just a minute, for the orthodontist, if we have any orthodontists in our listening audience, you'll notice some intrusion springs. The mechanics or the appliance was double and triple buccal tubes, and using one of the auxiliary tubes, we were able to put some intrusion springs in to facilitate the bite opening, and also helping with the cant to the maxillary occlusal plane as well. So those little devices here are just the anterior portions of those intrusion springs.
And what I thought was so great, Colin, is that right after your surgery, you sent me one of these slides so that I can see the dehiscence and the absolute need for this procedure, so that when I saw Brenda at the office very shortly thereafter, I could re-emphasize the need for this procedure. And that really helped to boost her spirits after this procedure. But without this procedure, this would have been a failure.
Well, it was certainly been a big concern for me. We may have gotten by with it by tipping the incisors and perhaps some soft tissue grafting, but having bone and soft tissue makes a world of difference.
And the corticotomy, which sets up the wrap effect, which sets up the osteopenic effect of bone, really facilitates greatly the intrusion process. Because if you go back to a lateral SEF and you look at the B point, you'll see that it's almost two fused cortical plates, and intruding into those two predominantly cortical plates is difficult. This is just an adjunct to that. Here we see the case following grafting.
You know, Colin's showing this. I think a lot of folks are kind of amazed sometimes by something called SureSmile, which is a virtual way of arranging the teeth as a finishing approach to orthodontics, and we use that. We typically, I mean, for the most part, on every comprehensive case, we use this technology, and this is just a clip of one of the images that we generate from this, and that would require discussion about SureSmile would require a lot more time.
But what Jim does is he sends me the image as to where the teeth are going to be moved, and that tells us how much bone to add in and how deep to cut the corticotomies.
For those who want to ask questions, I see one hand raised right now. If you can just go to the Q&A section and type in your question, we'll ask that question at the appropriate time, likely at the end of the presentation. Thank you.
Superimpositions of before and after SEF. You can see that the maxillary incisors were retracted somewhat and the mandibular incisors were advanced somewhat.
Would you talk a little bit, Stella and Jim, about your input, because I've heard the two of you talking many times on different patients, of your input to Jim and Jim's responses to you relative to where you want those teeth set and how you can both achieve that to the best of your abilities for the patient's benefit.
Well, incisal edges are important, but we're finding in these restorative cases that gingival margins are maybe more important, particularly if you're relying upon someone as good as Estelle to provide the restorative. So we look at that pretty closely.
And as an ongoing process.
As an ongoing process, but most of these things can be figured out ahead of time, and if you proceed with the knowledge that this is what it's going to wind up being, then things are just a lot more effective and efficient. And it's probably a good time for me to mention that this whole comprehensive orthodontic treatment was estimated at about 18 months, actually took 19 months, and was a total of 11 visits.
Wow.
I think the collaboration was enhanced by being part of the study club together, because we, over a series of years, have come to understand what we see as the best and ideal endpoint for each of our therapies. And so over time, it's made our discussions easier to negotiate and to understand the challenges that we both have.
Yeah, so what you're really saying is that we're learning from each other and acknowledging each other's limitations and advantages of what we do. So
That's right.
It's been a pleasure.
But that's absolutely correct. All right. So here we have, as it says, our pre and post orthodontic setup. And as Jim said, and I couldn't agree more, it's much easier restoring teeth that look like a typodont rather than restoring teeth that are so jumbled. And if I can just get onto the soapbox for a moment, when we see these cases that have had instant orthodontics, in other words, a full mouth of enamel destruction and restorations bonded onto them, I mean, that's really not fair compared with the way Estelle and Jim have set up this case to create such beautiful arch form and tooth position ready for restoration. Again, it looks like a typodont. So, moving forward, just some comments as we go along. I would like to point out the spaces that Jim provided to Estelle upon her request moving forward in the restorations, and notice the extent of arch expansion, some commentary and discussion that went along. Estelle commented, and she said a few times, it was fascinating to see the progress of the widening of the arch. I tend to believe that the patient is healthier without the crowded teeth. Dr. Gray, when you have mandibular crowding and overbite, you have to move the maxillary incisors temporarily out of the way, as you said. Estelle said, and I then figured out the spacing relative to tooth size and desired overbite and overjet. The spacing was adjusted accordingly. So, moving on. The case is now ready to restore, and the patient is in Estelle's hands. Estelle has a new treatment planning session with the patient, and if I remember correctly, it's been a while. You decided you needed these tori removed. You may remember corticotomies and augmentation were provided only in the mandibular arch, nothing in the maxillary arch at that time. You then decided you needed more crown length to restore, discussed it with Brenda, and sent the patient on for me to remove these tori, which I will comment was an arduous task.
Yes, and we, after every orthodontic rehabilitation, we start with our initial records of face bow and new models and diagnostic wax up and a full series of photographs. We share those with another co-diagnosis with the patients so that we can reestablish their goals and values as they may have changed during the treatment.
And that's where we are with Brenda at this
Yes.
time. So Estelle then sent Brenda back to me, and I got to work, and every periodontist in the group will know that this is hard work. And we did it.
I think you sent me a picture of that right
Yeah,
after
and
surgery,
this is
too.
the Taurus.
You're pretty proud of that.
I'm very proud.
I'm impressed.
This has actually been at many places, but look at that. And we did appropriate crown lengthening. The question that in hindsight is maybe we should have done this before and might have just facilitated some of the orthodontic movements, setting up that wrap effect. Now we go into the rest of the program, which relates to the restorations. And Estelle, oh goodness, I so apologize for flashing back and forth there. Estelle, would you like to just talk a little and the sequencing and such like?
Brenda was very clear that she did not want the expense of placing restorations on the lower teeth. So she used the opalescence tray white disposable trays every other night for 3 weeks, and was satisfied that the teeth were as bright as she would have them.
Okay.
And we, as I said before, we have the new evaluation of the teeth, the photographs, full records, co-diagnosis, and Brenda did choose not to do some of the mandibular restorations we had recommended. A short while after we had completed the case, she did choose to replace one of the mandibular crowns because it was submarginated on the distal, and the crown did not cover the foundation on that tooth. So we redid that one crown.
I do want to point out again, because that is the message we'd like to get out tonight. Today, I saw a new patient, complex issues, and I thought to myself, this is going to be a good study club case. The patient was referred to me for 1 or 2 specific procedures, but when we looked at perio, teeth, myofunction, and aesthetics, he had issues in all of those departments. And when I spent an extra few minutes speaking with him, suddenly he was interested in all of what we discussed. I thought to myself, this will be a terrific case for our study club case study. And I asked my staff to get comprehensive records. Now, what we've set up to now may seem an ordeal, but the reality of getting those comprehensive records were like 4 minutes for impressions. My staff are phenomenal with photography, so it was like 6 minutes for photography, 8 minutes for a full mouth set of x-rays, 6 minutes for a CBCT scan and panoramic type bite wings, and whatever I've missed out was less than 10 minutes. So in 30 minutes, without any of my time, because quite frankly, I cannot do that type of stuff as well as they do it, we had the full record. I had done a tooth and periodontal chart, and we've now got these records forever. Whether the patient chooses to go into treatment now or postpones treatment, we've got those records, and that's our baseline. Again, when it comes to moving into the next major phase of treatment, those records are not cumbersome, but they are invaluable, and the patient loves it. Now, some will say, well, what will insurance cover? And my comment, and please excuse me for being very blatant, my comment is, I don't care about insurance. We're not charging you for these records, and whatever expletive you'd like to put into that, the insurance company, because they are not paying for that patient's well-being. So these records, and that is the message we'd really like to take away, records and co-diagnosis and treatment planning and collaboration is not a cumbersome process once your system is set up.
It's really peace of mind for us and for the patient.
Absolutely, and the patients love it. You know, so we don't charge for all of these records all of the time unless there's time involved in analyzing the data, as the orthodontists have. Yeah, okay, still moving on.
The laboratory provided a wax up of how they envision the case proceeding. I'll make the provisionals from these records, And we'll also complete in the office before we start at an appointment that's separate from the initial prep visit. We will use a matrix to show Brenda in her mouth what this wax up will look like before we begin. We call that the trial smile. Some people have heard of that. And she's able to give feedback on how it looks for her, and we can evaluate the length of the teeth and the shape of the canines or the embrasure spaces at the incisal edge. We can evaluate with her the width of the restorations on the posterior arch. All of these things can be known beforehand, and I think it makes for a much more comfortable visit when they come for their prep visit.
I do want to put in here that I think that this diagnostic wax up to develop a trial smile and such like is the responsibility of the restoring dentist. And I have been present on a number of occasions when I've heard or overheard Estelle talking with a lab. Yes, I want this at this angle and this at that angle and this so high and so short and so whatever. And I don't know what she's really asking for. But the important point is that it's not a question of send models to the lab or casts to the lab and they send you back a wax up. It is what do you and the patient envision relative to that.
We're also working out function. We're going to know if there are any interfering cusps on the lower arch as the canine and anterior guidance is established. This will decrease muscle activity, propensity for headache, and also decrease risk for fractured teeth in the future.
And so I think it's absolutely important that the dentist is involved. There are some teachers around the country. The one that comes to mind would be Neil Starr, who does the intraoral mock-up. One of our study club members, Bill Carroll, does an intraoral mock-up with wax, but there is something that the dentist is providing, however they choose to do it, in order to help the patient understand where they can be going and what can be done and provided, and also for the patient and their family to give that input. Moving on with the restorative phase, Brenda was then sent to our office for crown lengthening and tori removal in the maxilla, which we did. Estelle provided me with a surgical guide, which I used relative to where she wanted her teeth positioned. She sent me the bisacral trial smile, which was indeed her surgical guide for the desired length of the premolars, more on the right side than the left. We allowed tissue to mature for a further 6 weeks after the crown lengthening. Today, I think we would wait another 12 weeks, a little longer.
Well, you know, that was more posterior tooth.
And that was more posterior.
On the anterior teeth, we would have waited more 3 months.
And Jim is happy that she kept wearing her orthodontic retainers. And she was already proud of her new smile prior to any restorations. Again, just to remember where we're going. Estelle then moved ahead with uneventful preps, provisionalization, and impressions. And again, my comment that we had developed for her, ideal typodont-like arches. Estelle, would you like to just talk about why you use those materials?
I don't
if
think
you would like to talk about the materials, you're welcome to, if they're relevant.
I don't think there was anything especially unusual about this process for me. It's what we do every time we have a case. We do make photographs every time of the provisional restorations and the shade tabs with the preps, and do everything we can to give the laboratory as much information as if so they can be in the room with us while they're restoring the case.
When Estelle said they do take photographs all over, she takes photographs. You may take 1 through 10, she takes 10 through 100 of everything. So she's got libraries of photographs on every case, which is amazing. Estelle, would you like to tell us how you in your office with your team communicate these shades to the lab?
As I said before, we make photographs with the shade tabs, and we'll use multiple shade tabs. We have a digital um, reading that we can show how the provisionals correlate with the shade that we want. Sometimes we make photographs of the provisional and we place the shade tab next to that because they may like the shade of the provisionals or want something slightly darker or something lighter. And we can use the provisionals to place characterization with stain on the provisionals, and we can do half of the arch to show the patient in the lab what the patient does or doesn't like. So there are multiple ways to use photographs and even videos in some cases where sibilant sounds are important. So we'll often make a video of the side of the patient saying certain words and phrases to develop phonetics.
And just a technical question, are you and your labs calibrated color-wise?
I would not say that we are calibrated color-wise on a case like this because the shades are going to be created for the full arch.
Okay.
And what is important for a full arch case in my practice is very often asking the lab not to create a custom shade, but to produce the shade tab, making it easier if something should break or crack to have a replacement made.
Great idea. Okay, this is what we spoke about now. Photographs for the lab, then a splintered temporary provisional restoration using that detailed vacuum form shell, the multifunctional acrylic composite resin temporary material, Visalaze, temp, whatever, Kattenbach. The position of the incisal edge was customized for the patient. Notice a lot of stuff is being done with the patient, by the patient, for the patient, in the patient's mouth. And then an impression of the splintered provisional restoration was made for the lab. In addition, you've got to remember the preventative side. She's now splintered. Home care is a little more difficult. At that stage, you had to rinse with the Nutricell supersaturated calcium phosphate rinses. I believe you'll be using the Perio Sciences product, the antioxidant rinse twice daily. We may discuss that later if people have got questions. Our goal is to support home care while the splintered restoration is in place, and that's so important to give you pristine gingival tissues as you are moving along. I could imagine nothing more frustrating than having inflamed tissue and then it shrinks and your margins are not ideal where they should be. And then, as you say, gingival tissues that are in optimum health prior to cementation of the final restoration are favorable when delivering the crowns. Isn't that the truth? Okay, then we move on.
And there are a lot of details here, and some of you can read those. The important thing to notice is that there are just simply a lot of steps. And so we have some lists that the laboratory wants of requests from them, and we have a system and a process in place that we make sure that we get what the laboratory needs to create what we're expecting.
And more details, I'll just leave this up for a moment. Estelle, if there's anything significant you want to comment on?
I think it's really important at the cementation visit to schedule plenty of time to check contacts, to make sure the margins on the crowns are closed, to make sure there's no fremitus on the anterior, and really look at that occlusion when you're at the delivery appointment, and also to support the long-term health of the teeth by making that impression at the end so that a retainer is in place and the teeth are stable.
Every detail counts. Okay. Would you like to comment there, Estelle? Because this, I think, is so valuable.
Well, you can see that Brenda was really happy with her restorations and was eager to make the photographs. I take a tip-down photo to know that the provisionals in this case are at the wet-dry line or the vermilion border, and I share that information with the laboratory so that Brenda will be comfortable in her speech, and she'll have excellent speech and a really nice smile and won't complain of bulky crowns and such. This was the exciting day. I do tell my patients the exciting day is really the day when you place the provisionals, and this was that day. It was just great, and we always tell the patients ahead of time that the day the actual restorations are placed isn't really the most exciting time. It's really a confirmation of what we've been testing all along.
Look at that animation in that lower right picture of Brenda. Okay, just some technical stuff. The trial smile, you know, the provisionals.
Right, that's the, if it indeed is the trial smile, this is the, I think this may be the provisionals,
Yes.
the day of provisionals, not the trial smile.
Oh, yes.
And
yes.
it may be also an indication of the restorations after she has worn them for some time. Just double checking and verifying the health and position of the gingival margins and the length.
And you would say that this is as important as the final because this is the template that you're going to base your finals on.
Yes.
Talking of the shade that we mentioned earlier, matching it up, photographs to the lab, every detail. All right, then I will skip this. This is what we do for home care on every single patient. If anyone wants that, that's on the website. And this is now her final panoramic. Pretty much uneventful. Nice embrasure spaces. Look what you did for this lady, Jim. Look at the embrasure spaces that she can now clean. I mean, look, that's just so awesome. That makes a periodontist's heart sing.
Make you happy.
Look at that. Makes me happy. I mean, it doesn't take much to make me happy, but look at that. Final images.
That's beautiful, Estelle.
Really, Estelle, as we've said many times. Left and right buccal. Look how the case was set up. Look at the gingival health. Finally, I apologize for the color here, guys, but the left is the before, if you weren't sure of that. The right is the after. Now, on the periodontal side, you might notice some modest recession on this tooth. And this tooth was the tooth that had the initial recession. And in hindsight, you may remember that in the back of my mind, I was continuously concerned about wide embrasure spaces. So my corticotomies around this tooth were very modest. I specifically remember that. And the grafting material was modest. In hindsight, I should have put more material into this area. But the comment from this is that Brenda's an extremely motivated, conscientious patient, and she knows that there's a possibility of a future autogenous gingival graft if we see any changes. And in these corticotomy PAOO cases, maybe 1 every 100 teeth, I will actually go back a year or 2 or more later, and if I see any change in the recession patterns or in any insufficient root coverage that I think might progress with time, we will do a little supplemental autogenous graft. So as goes with all gingival augmentations, predictability is sometimes unpredictable, and patients are aware of this. Okay, did we meet Shish's aesthetic guidelines? Indeed, I think we did. As Jim said, the case is quite beautiful. If I could figure out how to get Lee out of the way. Oh, look, Lee, just for a moment. I'll put you back in a moment there, Lee. Okay, the incisal plane, profile, length, smile line, tooth proportions, gingival outline, tooth shades, intrinsic characteristic, buccal corridors, and lip support. And by the way, this case was presented to Jerry Shish in his residence at the Medical College of Georgia, and he was jubilant over the results, I might mention. Let me put you back, now that I figured out how to do that.
Colin, it's only showing up on your screen, so don't worry about it.
Okay.
I'm not seeing me on your screen. It's okay.
Oh, okay.
Okay.
All right, so her final images. And as I've said, I hope people don't take offense. She is glowing here. Look at that smile and the facial expression. She absolutely loves what she sees. So it takes a lot of planning to come up with a wonderful result for a wonderful patient. And Brenda has since moved out of town and lives quite far from us. We tried to get her in to come to Atlanta to do, for us to get final records to present. This is about 5-year follow-up. And she sent me this email, which I would like to read. The only trouble is my reading glasses are downstairs.
Would you like me to
Jim,
read it?
would you please do the honors? This is Brenda's email to us just a few weeks later when we were putting this presentation together.
Hello, Dr. Richman. It's so nice to hear from you. Hope all of you are doing well. Otto and I are doing well. It's been a very challenging year for our family, but we are looking forward to a wonderful 2019. I can honestly say I have not been back to Atlanta since 2016. We are settled in our new home and enjoying the slower pace of a small town. I'm extremely proud of my new smile and am fanatical about caring for my investment. I have had regular dental follow-ups and everything is doing well. My lower fixed retainer is still in place, and I wear the upper and lower retainers every night. I can't literally sleep without them. My dentists here are extremely complimentary of the work done by my Atlanta team. I miss seeing all of you. You are such an integral part of my life during that time and process. I'm working full-time, but if I ever plan a trip to Atlanta, I will certainly contact you and come for a visit. I think of you every time I smile. Your care, concern, skill, artistry, professionalism made that process as pleasant and as expedient as it could be. Please give my best regards to Dr. Zanstra and Dr. Gray. And she goes on to say, thank you for contacting me, and I wish you the best.
So another satisfied patient. I think, Lee, that is the end of our program, and we are keen and happy to take and answer questions and dialogue. And I would say if anyone in our group has got questions, please let's have them.
What a terrific presentation and a terrific result. The three of you did an outstanding job for this patient. Just amazing. Well done.
Well, we couldn't have done it without each other and without our teams in the office to make it all happen. It was a real team effort.
You know, Lee, when we try and teach, and you and I have had these discussions into the wee hours of many nights, many times.
Yes, we have.
You know, Lee and I, it's not unusual, 2 in the morning, 3 in the morning, we're talking. But when we've had these discussions, how does one get started on this interdisciplinary treatment plan? You know, we present a case, it's a nice, pretty case, a lot of work went into it, but that's not the purpose of this. The purpose is how do we get started on this type of case? And whenever we teach this, my comment is everybody has got these cases in their office. When a study club director says, I can't get anyone to present a case, you know, that's ridiculous, because everyone has got these cases where at least if we offer the patient the opportunity, they can pursue treatment. And I say, identify one case like I did today. Get comprehensive records, sit with your team. I say, and I hope I don't offend anybody, no single dentist can do it all. There's a number of super dentists around, but nobody can do it all. You have got to have the support and the respect and the devotion of your team. And one case leads to another, leads to another, leads to another. So on Monday morning, one won't have a rehabilitative practice because they watch this program, but identify one program, it does one patient, it does not have to be a patient where one is going to add to their revenue stream, but do it for the fun of our profession and for the fun of why we went into dental school, into dentistry in the first place, and for the satisfaction. One leads to another, leads to another, to another. And of course, we are proud to say that with all the people in our group, we've got these cases and we love them and we enjoy them. Somebody once said to me, the maturity of a restorative practice is when one can walk into their lab and they've got 6 adjustable articulators with cases all going at one time. And this is where it can lead to, but it's baby steps before we can walk, run, or sprint.
It is, and a big part of that is looking and is working and is discussing with the patient what the patient's needs and wants are. And that's not a simple process. It requires listening skills. It also requires accumulation of the diagnostic data. Now, Colin, you know this. Estelle, you know this a little bit as well. When we're getting our diagnostic data, as you mentioned, Colin, we don't charge a lot of money for that. You know, if you're going to say it's going to cost $600 or $800 for a workup, you're going to discourage people from even getting the opportunity to see what they could be like, what they could look like. So I understand we all have investments, and a lot of investments in time and staff and offices and everything like that. But in my experience, if at the front end we're very giving of our time and our diagnostic expertise, including our diagnostic technology, there's a much greater opportunity for acceptance of treatment. We just have to think in that direction, and frankly, it will happen. Colin, I agree with you. We all have patients like this in our practice. Let me read a comment for a moment from Alan Rosenfeld, who's a fine periodontist from Chicago. And what he says is this is a wonderful example of effective interdisciplinary communication resulting in comprehensive treatment. This is exactly how our team functions under the direction of Brian Bense and others. The co-discovery process gets the patient involved in supporting and understanding treatment decisions, and nothing could be closer to the truth. And just to give a plug for my own organization, the Institute for Dental Specialists, which helps dental specialists all over the country in running your practices. Brian Bense will be presenting a program on exactly what he does with regard to co-diagnosis, and that'll be coming up shortly in February or March. So if you want more information on what the Institute for Dental Specialists can do for you, just write to me at lee@directorofdentistry.com, and I'll be happy to give you more information, or just reply to the email that you received on the Zoom platform when you signed up for this for this program. A question comes in: did the migraines continue? What kind of comments can the three of you give us on that?
What continued?
The migraines, so the headaches.
No, they stopped. Correct. Yeah,
now, that's interesting. And at the beginning, you said you would elaborate on that. And part of your presentation was, and it seemed like this, Colin, an implied promise that the patient's headaches would be better. Is that what occurred, or what happened in the initial case presentation with regard to the headaches?
During the orthodontic therapy, the headaches were completely gone. And for a topic for the other day, we can understand a little bit more about why they may have returned just a little bit. She would always complain about a tight band along the back of her head. And that did go away during the orthodontic process, and then returned just a little bit and not quite the same intensity. And she was satisfied that her overall health and comfort had improved after treatment.
My
Very
experience
good.
with these types of cases is that, you know, migraines are often misdiagnosed.
Yes.
You know, a migraine is a vascular headache, but it seems to be often precipitated by myofascial kinds of pain. And so it's not uncommon to have a great improvement for the patients with
That's
their
right.
headaches.
What I do remember is that when we started seeing her post-treatment for maintenance, from what I remember, I'm open to correction, but all of the medications she was taking for migraines had terminated. She really wasn't taking anything else once the case was finished. And of course, you put her into an occlusal guard, which she told us
Yes, I believe we
and she
did.
tells us she can't live without.
Yes.
And I agree with that.
What did you tell her at the beginning with regard to the headaches? Was because at least in the presentation,
I
it was a
basically
significant
tell them
issue.
thing, whether, you know, just as I stated, that, you know, that migraines are sometimes precipitated by the myofascial approach, and often they do improve. That's with not making a definitive diagnosis of a migraine, but they often do improve with orthodontics and restorative dentistry.
What I think is really important is to make the patient aware that changes in the occlusion, changes in how the jaw functions, and changes in the muscle activity after this type of rehabilitative care may occur because of it. And the reason that that's important for them to be aware of that is because they need an avenue to investigate why these things may have returned later. It could be 5 years later, an interference could have developed over time as the teeth shift and jaw changes, and it may be important for that person to know, oh, maybe I should see my dentist who may identify an interference. We can eliminate that interference, and then they may be doing better. So it's important for them to understand that's a component of their overall care.
Sherry would like to make a comment on the migraine question.
It didn't have to do with the migraines. I want to go back just for a moment. When Dr. Richman talked about doctors saying that they don't have the patients that will do some sort of interdisciplinary team treatment, don't prejudge patients, because sometimes the patient that you think would never do anything will go and spend $60,000 on treatment. So you really need to give patients the opportunity to choose the right thing, because in many cases they will.
Patients don't know what's available until you spend the time to educate them.
That's very true, and having gone from referral practice to direct-to-patient practice, I can testify that it is not. Please don't prejudge patients. If you're looking at income levels, we get acceptance of treatment at all income levels, not just the high income levels. So it is a matter of showing a patient what he or she could be like, could live like, how he or she could experience life. And believe me, there are a lot of people out there. Just look at the dental implant clinics right now that are advertising on TV in markets all over the country, and people are committing $50,000 or $60,000 to those restorations. If they're doing it to just extract teeth, place implants, and place a ceramic restoration, it's a good thing if that's what the patient needs. But if they're doing that, we can do that too and save the patient's teeth.
And Lee, just to comment.
Oh, Colin, could you go back on full screen? Just do stop share.
Just to stop share.
Yeah.
And Lee, just to comment. Oh, hi.
Hi.
Just to comment that the organization that you have founded of dental specialists really addresses that to the maximum, providing comprehensive care to that group of patients, to that community who don't know what's available. We are very privileged. We've got a wonderful, motivated group of restorative dentists and others in our dental Seattle study club here. But there are so many patients out there that should know of what's available And the only way they can be made available is, as Sherry says, bring them in, spread the word however one chooses to do it, get the records, sit down, as happened to me today. I mean, I'm not making the story up. The guy was sent to me for a consultation about 2 molars, can they be uprighted or not? And by the end of the time that we spent together, in less than an hour, this is a comprehensive interdisciplinary care case. I don't know what he drives. I don't know how much money he's got in the bank. I don't know where he lives. All I know, he's a very sweet, pleasant man, and he sat there with his mouth open. What can be done? When I told him that I'm probing him, and every time I touched his gingiva, he jumped out of the chair. I said, you know, that's, and he's in paramedical sales. We spoke about health and everything else. Just give that patient the opportunity, and indeed he signed up for everything we suggested and will suggest, and it'll be a big interdisciplinary case.
I can give you an example of a night watchman, and you know what a night watchman makes, and saw what could be done, and even with that kind of an income, found a way to make it happen. So yes, do not prejudge patients. Let me ask a question, because I use it, but I want your comments. I found cosmetic imaging to be a useful adjunct at the initial patient examination, where we insert a sample smile between a patient's lips digitally. Do any of the 3 of you use that? Any comments on that at all?
Lee, I'm going to go back to the lesser screen because the sound is not coming through well. Is that what I do, Jim?
Try it and see.
Okay.
Okay.
Say that again.
Do I sound any better now?
Much better, yes.
You look better too.
You also look better now that you've been minimized.
Okay. So the question was one of cosmetic imaging. Do you find that to be useful in your initial examination for the patient?
I don't use a lot of cosmetic imaging. I show cases that are similar to the patient and get their feedback on what type of smile they want. So we talk about what type of smile do you like in by looking at other samples of rehabilitations from other patients. I have used the digital imaging a couple of times. I haven't seen an aha moment with that alone. I think it's in combination with the 2-appointment preclinical and co-diagnosis visit, where we get to know each other and establish a relationship with each other and learn to know that we are who we say we are. And as we dive into the values that we share together and what their goals are, I think that as they recognize the values they have around their teeth, we come to a decision together on what will meet their goals over time. So for me, in what we're doing and how we do it, it is a nice adjunct to everything, but it hasn't been a major role in my practice.
Okay. Are there any we're out of questions here. Are there any questions from your group?
No questions, comments? No, we are done.
Well, good. I thank the 3 of you for presenting this. I think this is going to be valuable to everyone. And thanks for doing this for all of us. We thank our sponsors again, BioHorizons, Gilead Dental Marketing, YourMarketingPractice.com, Stella Life, and Ace Chat for sponsoring this program. We thank Dr. Richman, Dr. Zanstra, and Dr. Gray for presenting preparing such an excellent presentation. For those of you who are following this, we are doing treatment planning sessions quarterly. Our next presentation, I believe, will be on April 16th, and that will be with Dr. David Matthews and Dr. Frank Spear. If you want more information about that, just contact us by the email or send me an email by the email that where you receive this registration, or contact me at lee@directorofdentistry.com. Thank you all. Thank you, doctors. Thank you, everybody, for joining us. Good night.
Pleasure, Lee.
It has
Thank
been
you
a
for
pleasure.
putting it
Thank you,
together.
everyone.